Well, welcome everyone. I think we'll go ahead and get started. This is the 11th webinar of the Living with SADS series that the SADS Foundation has offered. And tonight on pregnancy with a SADS condition from the patient perspective. I'm Marcia Baker, Program Director for the SADS Foundation. Before we begin, a couple reminders. One, if you would keep your audio muted during presentation, talking, etc., to improve the sound quality. But we encourage you to turn on your videos and engage with each other. You can put your questions and comments into the chat field, or you may, raise your hand, ask a question, make your comments verbally, and just unmute yourself. We welcome any way you want to do that. Our webinar is being recorded today, and it can be viewed later on the SADS YouTube channel. So I'm going to briefly introduce our three moms and where they're located, and let them share their respective journeys of pregnancy with long QT type 2 and the lessons learned along the way. So first we have Suzy Burnt from Kalamazoo, Michigan, and we'll have Kellie Moore, who is in Salt Lake City, Utah, and Melissa Russum, who is from Clifton Park, New York. We also have two medical specialists from last week's pregnancy webinar joining us again, and they volunteered to address any medical questions related to pregnancy and a SADS condition. And those are Dr. Danna Spears, who is an adult EP from Toronto General, and Dr. Janette Strasburger, who's a pediatric fetal EP from Wisconsin Children's in Milwaukee. So if you missed last week's webinar, you can check out our recordings on our YouTube channel as well. So now I'm going to turn it over to Suzy to share her journey to start with.
Thank you. So I'm Suzy. I live in Kalamazoo, Michigan, and I just had my first child on May 1st, 2020. She's 10 months old now, and she's doing really, really well. But she had kind of a tough start to things, which mirrored what my story was too. She's actually following in my footsteps really, really closely. She was originally due May 16th of 2020, but let me go back even further. So when I was born, I was diagnosed with long QT type 2 right at birth. And I was fortunate enough to be born in Ann Arbor, Michigan, and to be born somewhere where they knew to think about that when a baby was born in distress. So I had been born across town at St. Joe's, and they zipped me across to the University Medical Center. And I had a pacemaker implanted as basically a temporary pacer put in, I think the same day, and then a permanent one put in just a few days later. I have done well with that overall. I'm on a beta blocker 2 as well. I'm on 80 milligrams of Nadolol, and I've been on a pretty high dose for quite a while. So I'm pretty used to it. I can say pretty confidently that I don't think I felt any impacts of my heart condition when I was pregnant. I didn't find that to be a struggle whatsoever. I would get tired easier because I was pregnant. Those who have been pregnant will know you can run out of breath pretty quickly, and you seem to want to sleep a lot more. But I don't think that was related to anything with long QT. For me, my pregnancy journey was a challenge because of the pandemic that started in March of 2020. I had a lot of appointments, basically, because Gabby had been diagnosed on her 24-week ultrasound, which we had ended up taking because we didn't get good enough images on the 20-week ultrasound. They had noticed she had a heart block, and so she had a very, very low heart rate in utero. And so that immediately started the process of everything moving forward a little bit quicker. So I got a lot more surveillance after that. And so going to the hospital before the pandemic started, being in the hospital while it started, the day of the lockdown, the day the pandemic in the world was declared, traveling between states, and then giving birth during the pandemic in the hospital. Those were all quite impressive challenges. But the big challenge was carrying a child who was diagnosed with second-degree heart block and long QT. Dr. Strasburger's study in Wisconsin allowed us to learn a lot more about Gabby than we would have known just from our fetal ultrasounds and from the fetal echoes that we were able to access at the University of Michigan. And so we were able to prepare a lot better for her arrival. Dr. Bradley, her pediatric cardiologist, did so much research and preparation and just kind of rallied the troops. And it was a whole team that was involved and waiting for her arrival when we had our C-section scheduled for May 6th, and it ended up happening May 1st. So all that preparation was great, just happened many days before everyone anticipated. So I think that's about all I probably need to share at the beginning as a way of introduction.
Okay,
but
thank you.
Yeah, Gabby's doing very well now. So that's
wonderful to hear. Thank you, Suzy. Okay, Kellie, would you share your story here?
Yeah, absolutely. Again, I'm Kellie. I also have long QT syndrome type 2. And so do my brother and sister and my mom and my grandma. So lots of us in the family. I've been through 2 pregnancies. My daughter is almost 4 years old. She'll be 4 in April. And she also has long QT syndrome. And my son is 2.5, and he does not have long QT syndrome. So I have a boy and a girl, and one with long QT syndrome and one without. And honestly, I didn't really feel that much of an impact from long QT syndrome during pregnancy. I think the first pregnancy, the biggest challenge was not anything to do with my heart, but morning sickness. And I finally, when first trimester ended, I finally accepted that it was not going anywhere and I needed help and I should just take anti-nausea medication. And I remember I was at work and getting a call from the nurse, and she said, we have 3 medication options. And so I pulled out my Credible Meds app and very quickly searched. So if anyone watching this does not have the Credible Meds app, that was a true lifesaver for me many times during pregnancy, but also just, in life. And we did thankfully find one medication that I was able to take. And I took it for the rest of my pregnancy. And then also with that pregnancy, my OBGYN wanted to do growth ultrasounds all the way through, just to make sure we were keeping an extra close eye on my daughter. I think knowing about my long QT syndrome, and then also I actually, like Suzy, take 80 milligrams of Nadolol. He wanted to just keep an extra close eye on her. And when we went in for my appointment at 37 weeks, there were a few things that were off that day. So I ended up having an emergency C-section. The amniotic fluid was low and the blood flow from the umbilical cord was low, but those were things that was nothing to do with my heart condition. Those were just kind of unfortunate things that happened and that I was glad that we caught. My daughter's heart rate was also low. And from what I've been told, that's likely because she has long QT syndrome. Although our experts here, please feel free to correct me on that if I am wrong. That's what I was told. And she also hadn't really grown much in the last month of the pregnancy. So that was also concerning. So she was 5 pounds, 0.8 ounces at birth, and she went to the NICU for low blood sugar. And then a few days later, we were living in Missouri at the time. And so then a few days later, she was transferred to the NICU at St. Louis Children's Hospital. And that's where we did a blood draw for genetic testing and waited the weekend that was on a Friday. And then I think we got her results maybe Monday or Tuesday. We waited for that. And then that's also where they went ahead and started her on propranolol when she was 6 days old. And so she's been taking a beta blocker ever since. first propranolol and now Nadolol, and she's doing well with it. And she is no longer a petite, tiny little thing. She's very tall. So she is doing great. And then when I was pregnant with my son, we were living in Texas. So I had different set of doctors. And that pregnancy, I felt much better all the way through, night and day difference, two very different pregnancies. And my new OB, like my old one, wanted to do growth ultrasounds throughout. But my new cardiologist, when he found out I was pregnant, recommended that I stop taking my beta blocker. And it just didn't sound right to me. Partially because I thought, okay, well, I took it through all of my last pregnancy and was never told any different. And also because I knew that the postpartum phase can also be higher risk for women with long QT2. And I believe Dr. Spears talked about that last week and how crucial beta blockers are. And so that just, I thought, this doesn't seem right. I wanted to be sure that I was prepared for postpartum. And also my daughter was only 9 months old when I got pregnant with my son. And so I was still like, postpartum from that pregnancy. So that sounded like a horrible idea to stop taking it. So around that time, I found out about a fetal long QT syndrome study being done by Bettina Cuneo in Colorado. And so I volunteered for that. It was just some kind of data gathering and questions. And then I also reached out to her with my question about beta blockers. Should I keep taking it? I feel like I should, but I was told that I maybe shouldn't. And she said, absolutely keep taking it. And I also happened to mention to her that I was concerned about my daughter being born so small. And I wondered if there was a connection there. And from what she told me, she said that women who take beta blockers do have slightly smaller babies sometimes, but that's more of statistical significance rather than clinical significance. And I'm sure our medical professionals could also speak more to that. That's the extent of what I know on that front. But that all put me at ease and also confirmed that I needed to find a new doctor, which I did. And he said, yes, take your beta blocker. And otherwise that pregnancy was very smooth, very different from my first one. I had a planned C-section there, but again, that had nothing to do with long QT syndrome. And the important thing with that was just making sure the anesthesiologist was aware of long QT syndrome. And he was familiar with it from a previous patient. So that really helped put me at ease. Though we did get one little surprise with my son. He does not have long QT syndrome, but he was born with some extra fingers and toes. So that was a fun little surprise. We have no clue where it came from. We never caught it on any of the ultrasounds. Although my mom said, I think I remember seeing something that looked like a little sixth toe on one of the pictures. So, but it was a surprise to us. And we did, in case you're wondering, we did have them surgically removed just so he doesn't have to struggle with that through his life. But I think for me, that was such a reminder that nobody's body is perfect. And everybody has something different in their lives, and that those things are just part of what make us unique and are part of our story and are part of what shape us, whether that's a little extra toes and fingers, or whether that's a heart condition, or whether that's something else. And so I think that was just sort of an interesting reflective moment for me. And otherwise, the only other thing about pregnancy is that I was on telemetry for the first 24 hours after both C-sections and had no issues. And both kids are doing great. And so that's my pregnancy story in a nutshell, a very big nutshell.
Good to hear, and such a positive attitude, Kellie. Thank you. Suzy, go ahead. Sure.
Yeah, Kellie, thank you for sharing all that. Gabby was also very small when she was born. She had growth restriction too. And she was 4 pounds, 13 ounces when she came out. So she was very little. And we spent a bit of time in the ICU as well, the Pediatric Cardiothoracic ICU at U of M. And again, the experts can say better, but our feeling was that it was related to the heart block, that she had, less nutrition flowing to her throughout her growth life, her whole life, even though she was full term. And so that was a bit of an issue for us. And I also had to advocate for myself about not changing my beta blocker. I was initially at my original OB practice, they had advised I switch to metoprolol, and obviously that's not the best practice at all. And so I kind of tattled and I went to another the academic cardiologist that I see, and was like, I don't think this is right. Is this right? And he wrote a very well supported letter to the practice about why I should not switch from Nadolol.
You were both advocating for yourselves on the beta blocker issue. Yes,
yeah.
Good.
But,
well, and what's interesting with my son too is that, like, so my daughter was so tiny and my son was 6 pounds, 14 ounces, like very, because I was sort of like, oh, is he going to be small too? But they were both, yeah, my daughter was, I got so many comments about she's so tiny. I was like, I'm well aware she's very small. She will grow. And then my son's just this, I wouldn't say big, but just more kind of average size, I guess, baby. And so.
Very good. Okay, so let's hear now from Melissa Russum. Your story, Melissa.
Hello. So I will start with full disclosure. I feel like some of my decisions were based on strict clinical guidance from the best of the best, and others were total gut choices, including deciding not to take my beta blocker for the first 2 trimesters. So as I hear Suzy and Kellie, kind of had the advice to come off of theirs and advocated to stay on it. I've always, whether rightfully or very naively, felt myself very safe. I also been on a low dose of 20 milligrams, which I thought, boy, that's probably not even doing much for me anyway. And I have an ICD. So I kind of, again, it was totally a gut decision. Plus I was surrounded by, I think all of us are now, anyone who's pregnant now, or this last 10 years is such a sort of naturalist type of push. And I was, reading the books about I was so determined to make sure that I did, was going to be nursing right away and doing organic food and like all of that stuff that I think that definitely pushed me in a way that I'm not sure that I would make that same decision again. I would probably, go back and decide to stay on my beta blocker, but no, open book here, no reason to hide it. The decision I made the first time around. But I feel like my pregnancy journey really started kind of at diagnosis, because I was in my 20s. So I was 23 and I was single. I was about to go to grad school. I was not in any way planning for kids. I guess I wasn't in any way planning for kids soon. But of course, a woman in my 20s, I'm thinking, I just got this diagnosis. What does this mean? And so I'm learning the stats about, each child will have a 50% chance. And I asked my cardiologist, well, if if I consider myself pretty low risk, asymptomatic, is that consistent from mother to child? And, and he didn't really know, it was an adult EP. He didn't really know, but I feel like I was starting to ask those questions right away. And I found out really that my cardiologist, who I think is great with me, but just didn't with a specialty like pregnancy, he just didn't know the answers to those questions, which through any SADS programming, I've learned that 100% no, it is not the extreme nature of the mother means extreme in a child, or the passive nature in a mother, that's not something that necessarily, is passed through, so that my kids could have a much more severe case than I do. So that's sort of, kind of what I've been learning along the way. And I have found that I've really been able to sort of supplement those question marks that I get from my doctors, because I'm a questioner. So it's not just, okay, I'm pregnant, now let's decide what to do. It's, I'm 23, about to go to Belgium for grad school without a boyfriend. And I'm like, so what happens when I get pregnant? And I'm like already thinking ahead of starting a family. So I definitely, leaned into SADS as a resource for that kind of information. And it was in the Salt Lake SADS conference. So I want to say 2012 or 2011. I was there with my parents and I heard Dr. Cuneo speak. She did the pregnancy session. And boy, if I didn't just like shove her name in my pocket, that was definitely, you know, okay, here's a resource. I've got this. I was engaged at the time. I was getting married months later. So then when I did get pregnant, I started seeing a maternal fetal medicine specialist in Albany. Very, very good practice, but like I'm sure probably most of us can attest to, they were used to dealing more with high risk in terms of diabetes or, you know, things like that are much more likely, not, or potentially a heart condition that's not long QT. So there was still a lot of questions that I would ask them and their answer would be, gee, I don't know. And that was hard for me because I was definitely raised as someone where, you know, I asked the doctor and they tell me what to do and I'm a good patient and I follow along. And so pregnancy was really the first time where I had to sort of find some answers for myself. And the big one was with my daughter, Cora, who's about to be 7 next month. When I was pregnant with her, with the MFM, they asked if I wanted to speak to a genetic counselor. I said, sure. And we talked and I was saying, you know, is there any way to test before she's born? I'd love to know. Again, I'm a planner. Like, I don't want to wait. I don't want all this time without knowing. And, you know, she started talking about an amnio and this and that. I remember I wrote Dr. Cuneo an email and saying they're thinking about, you know, about an amnio. And her response was probably as clear as it was to you, Kellie, about the meds, where I was like, no, don't do an amnio. Come out to us in Wisconsin. We have this way of testing that is non-invasive. And so I went out to Wisconsin at around 20 weeks where I met Dr. Strasburger. And that's where we found out that Cora did also have long QT. And then from that point on, it wasn't just the diagnosis. I went back to my MFM group here in Albany, New York. And they had me set up with more appointments, more monitoring, but they also had me do consultations with anesthesia, consultations with pediatrics in the hospital, consultations even with the NICU, because they were really, you know, trying to be as prepared as they could be. Every one of those consultations that I went on, they opened up their notebook and here was this note from Dr. Strasburger that they had. And so there was just, my doctors in Albany like had you know, a pediatric fetal EP on like kind of on my care team, it felt like. And it was, you know, everything from, you know, different scenarios, what to do during birth. And then the same thing happened with my second daughter, Kate, who also went out to Wisconsin again 2 years later, also positive for long QT. And we had the same care plan. You know, we still went and did those consultations because we had sort of like a different group available. But then the deliveries were fairly uneventful. Both, you know, kind of no induction, just, you know, natural vaginal births, no issues. Cora, her heart rate was pretty low. And I think if she hadn't been delivered about when she was, you know, there's a chance of a C-section to deliver her because her heart rate was dropping. But they both started in the NICU on propranolol, and they were in the NICU really just for monitoring to make sure, and then kind of came out and have been on it since day one. So both of my girls now, 6 and 4, have been on meds since day one and have adapted incredibly well. You know, are the smartest, brightest little girls. So that's kind of my pregnancy journey in a nutshell, I would say. And having seen Dr. Strasburger here, like, she was like my rock during pregnancy. I was like, you know, with so many unknowns, so many questions from cardiology side, from, you know, maternal fetal medicine, from pediatrics in the hospital. Like, this isn't an, you know, a long QT pregnancy, a long QT baby isn't an everyday occurrence. I feel like, you know, for Dr. Strasburger, it is for you, you know, and so that was just really great to have as part of my plan.
Thank you for sharing your story, Melissa. And I think I'll ask all of you and then anyone out there that would like to turn on their camera and respond to this too. One of my questions is, what would you consider your most challenging aspect of your SADS pregnancy?
I'll start off. I think basically what Kellie and I discussed was one of my more challenging things was trusting myself and trusting what I knew that I understood, and speaking up for myself in these appointments. You know, I'm very comfortable advocating for myself when it comes to my heart condition with primary care or other medical settings. You know, pregnancy was a whole new world. There's a lot of stuff I didn't know. There's a lot of information out there that was contradicting itself. It's, you know, like Melissa was talking about, the whole naturalist movement of trying to be as minimalist as possible with things. And yeah, it was very difficult to kind of go against the authority figures that I was looking to in managing my pregnancy and saying, I just don't think that's right. So that was kind of the harder thing for me. I mean, the other one that was a big challenge, kind of goes without saying, was learning how to manage everything that came with Gabby in the pre-delivery time. You know, a lot of MFM appointments, a lot of monitoring at two different hospitals on two different sides of the state, and that was pretty tricky. And just the emotional aspect of that, which is, you know, can't even really scratch the surface of that at this point.
Very good.
I think for me would be just making sure to advocate, or if you know, getting, which I didn't get a ton of conflicting information. Like really for me, it was just the beta blocker thing, which is pretty big. But just, you know, sorting through and making sure that I had the right information. And then for us, we didn't get, I didn't get testing done for the kids before they were born. I think I found out about everything in Wisconsin like later, and I was like, oh, that would have been really cool to, you know, to do that. But so just kind of not knowing, kind of waiting and not quite knowing, okay, do they have it or not? And so, you know, once we got the testing done, you know, the NICU orchestrated that in Missouri. And then with my son, I had talked to his pediatrician in advance. And so she was able to get everything in place to get genetic testing right away for him. And so I think just the kind of not really knowing, that was just sort of it. I wouldn't say it necessarily stressed me out, but it was just sort of this unanswered question of like, okay, well, what is this going to look like? Is this child going to have this condition or not? And I think for me, like all my siblings and I all have it. And so I think there was also a sense of kind of expecting like, okay, probably they're going to have it. And then my son, as it turns out, doesn't. So I think just kind of the waiting a little bit was a little bit of a challenge.
Yeah, that even though I did, you know, find out during pregnancy, it was still like every week, right? It's a challenge to not know. And I think both Suzy and Kellie have said about the uncertainty, sort of, it's advocating for yourself, but it's also the uncertainty where it's not just advocating for yourself, but it's sort of finding the answers yourself and educating your own care team. So there were things about, you know, it's hard because, like I said, I sort of grew up, you know, in a way, I just naturally sort of believe, well, this is a doctor. They're the top, you know, they're the top of their game. What they say goes. I would love to not even have really room for I would love to just have sort of a directive of, hey, do this. I follow it. It's from a trusted source and boom, I'm good to go. But it wasn't that. There was a lot of room for my own education and my education of my care team. I remember, you know, questioning in an appointment about the use of Pitocin, because I learned with Cora, with my oldest, that even, you know, I knew that I was going to fight Pitocin if I needed an induction, or at least ask the questions about its necessity and kind of that sort of thing, based on just, you know, my minimally informed about, or as much as I could be informed about it. But then I found out that it was actually a routine part of care after birth. And and it's sort of, that's something that came up with the birth of my first daughter, that I was like, well, I wasn't prepared for this. You know, what do I say? Do I push against this, or are they right that it's like, look, in the best world, yeah, you'd avoid that kind of, but it's not that big. I was just sort of, I don't like being in those situations. I really like black and white situations. So it was very challenging for me, for the most important thing I'd ever done in my life, to be hurled into this gray area where I didn't want to be the one making these decisions. You know, I didn't want to be finding the information on it. I wanted the people who were caring for me to just tell me what to do, and I would oblige, even if it was painful, or, you know. So that was a huge challenge for me. I would say that was the number one, was just not having necessarily like a black and white world. And I really wanted one. There's so many other things to deal with in pregnancy. Like I didn't,
Right.
you know, I want to worry about picking a name, not whether or not to take a certain drug or what to do during birth.
Regular stuff.
Yeah.
Does anyone want to comment from our attendees and our participants, if you have a challenging aspect you'd like to share, or any question you have right now, you can unmute yourself and ask. Judy?
Yeah, may I ask a question?
Go right ahead, Judy.
Couple. My name is Judy Standifer. I have two daughters with long QT type 2. And my first question is, do Suzy and Kellie have ICDs? I know Melissa
I do.
said she.
Yeah, I have an ICD pacemaker.
And I do not.
So Kellie does not and Suzy does. And did any of you have your first baby in your 30s?
Me.
Okay.
Yep.
Yep.
Okay.
I'm trying to think how old I was. I would have been like 29. Yeah.
Almost. Okay.
Almost, yeah.
Thank you. I have one daughter who is choosing not to have children, and that would have been regardless of any diagnosis. My girls were not diagnosed till they were 19 and 23, and we had no idea what that was, that it existed, and have traced it back 100 years to great grandmother. So how did you feel then when your children were diagnosed with it, having lived it yourself?
I think for me, I was diagnosed when I was a child. And so I've, as long as I can remember, I have lived with it, and have known, like, I have lived a very good, very fulfilled, very rich, happy life with it. And so I think knowing that I had lived this life with it, and also my siblings, I think that put me at ease, knowing like, okay, it is very possible to have a very good, pretty normal looking life with this condition. And so that it was just going to, and one thing my parents did really well was to instill in us that we are not defined by this condition. And so that's something that I hope to instill in my kids. And so for me, it was more of just, okay, I know the answer. I didn't like the uncertainty, but just knowing the answer, like, okay, she has this condition. I know how to deal with this and how to handle it.
Thank you.
I think I felt that way too, where my family saw the worst side of things, because I was diagnosed when I was 22, because my sister died suddenly when she was 24. So that's what brought long QT into our lives. So I knew the side of lack of awareness. I knew the side of not being treated. And I immediately, within, she died in June, by July, I had an ICD in already. And I was on beta blockers, and go back to how I started by saying I feel very safe and low risk. And I know it sounds kind of counterintuitive, but I'm on, a low dose beta blocker. Whenever I go, my QT wave is always pretty, I'm never even close to 500. I feel like I've been asymptomatic my whole life, and we can, kind of looking back, I can see symptoms with my sister. And so I felt like, you know what, my eyes are wide open now. And I feel like I'm safe, and I had a safe childhood. And I felt like I had sort of the knowledge available that I could, raise my girls very safely, just like Kellie said, you know, with, I knew how to manage this. I knew that it meant medication, and I knew that it could mean hardware. I hoped not. I still hope not. Neither of my daughters have an ICD, and they're both fairly low QT levels and asymptomatic. So my hope is that they will never need one, but I know that that's kind of worst case scenario. So that was sort of in my decision making.
Thank you.
And for me, Judy, I wish I could say I felt the same, but I'm actually still grappling with it a bit. While I was diagnosed at birth, and so I have lived with this for nearly 35 years, and I too have had a very good life. There are, it's a chronic medical condition, and it comes with a lot of stuff. Like there's a lot of things that go with it, as any patient knows. And I don't have to go into it, but I'm still kind of grappling with the fact that, we put a device in her on day 6, and, she needed it. She really needed it. And she needed that temporary pacer that she got, within a few hours of her life. And the thing is that she received the intervention that was necessary even sooner than I did. And because she was at the center, she was at the expertise center, and was able to get that treatment right away. And so we were able to avoid any serious complications right at the start. But it wasn't a simple decision for me. And I think for a lot of people, it probably isn't. And I'm sure Kellie Melissa was telling how how many questions she had right away about it and what it meant, but I don't know. I go back and forth. For a long time growing up, I was told that I shouldn't have children, and as medical knowledge has advanced, that thinking has changed. I mean, everyone just kind of knew what they knew at that point, which wasn't as much as we know now. And so that kind of guided my thinking too. And it was later in my 20s really that I started thinking like, maybe I could do this. But finding the right partner helped. Having a good husband by my side really helped me be more interested in pursuing that path. But I personally, just in full disclosure, I had several complications in my mid-20s, all related to my device. And I, probably over the last 8 years, I think, I've had maybe 3 different devices, which is a lot for me. And just a lot of unforeseen complications. And so I think about that when I think about, having Gabby and passing it on to her. So those are just, sorry to get so heavy about it, you guys.
You're all sharing.
Yeah, that's stuff that I contemplate.
Yeah, in a committed relationship, and her electrophysiologist had said if he probably wouldn't carry a child. That was his initial advice to her.
Interesting.
Okay, so
I think having a very supportive care team really helps too.
And
yeah.
Going to get a new team. He moved out of the country, but she had him for 13 years, 10 years, 13 years. So anyway, I'm just trying to gather information. So I appreciate all of your sharing.
Thank you. And we have a few questions in our chat. Sarah asks, Suzy and Kellie, what do you usually run for your QT interval?
This is horrible. I don't actually remember my latest couple. I thought I had it in my phone, but I got a new phone and it's not there. So I'm sorry. I don't actually, I know though I've always sort of been, I remember as a kid, I was told like, oh, you're borderline. And so mine has never been very, like, it's always been kind of look close to normal looking. And my daughter's has always been very close to normal looking. But I'm sorry, I do not remember the number.
Close enough. Suzy,
Yeah.
do you know yours?
Yeah, even with my therapies that I'm on, I'm 550s, I think I could say, but it kind of bounces. It's above 500. If it swims around 550, between 525 and 550.
Very good. And let's see, Dr. Strasburger has asked, did any of you choose to breastfeed? And hold on a second here. And did you notice any side effects from breastfeeding? If you did, while on the beta blocker, and what beta blocker were you on?
I actually wanted to ask one of you about this because I breastfed both of my kids. I was on 80 milligrams of Nadolol with both of them, breastfed with them. I was never told to do any differently by any of my doctors, any of my kids' doctors, not by the lactation consultant I saw. I didn't notice any side effects. I had a hard time breastfeeding my daughter, but I think part of that was like first baby. She was early. It was all very new. And I got help from lactation consultants and that. And then with my son, it was like, okay, we kind of know what we're doing now. I didn't notice any side effects. And I actually wanted to ask about that because I've seen in one of the long QT syndrome Facebook communities, people saying they've been told not to breastfeed. And so I actually wanted to ask, like, what the advice is on that.
Everyone was advocating for me to breastfeed. We struggled with it though, because Gabby was so small. And during the 2 weeks that we were in the hospital, she ended up losing weight before we were discharged. And so we had to start fortifying her feeds. So breastfeeding was just kind of like just for bonding and because Gabby liked it. So we just did it a few times a day and the rest of it was pumping. Just weaned recently, so it's great. But
congratulations.
Thank you very much. I can eat dairy now. But it's been, I don't think there were any side effects as a result of taking any beta blockers, and I'm on Nadolol. But Gabby was on the same beta blocker, so I don't know. I couldn't tell. She's not a lethargic baby either. She's really high energy, so. Yeah, I don't think so.
And Melissa?
My girls were both on my medication too. I was on propranolol. I actually had normally been on Nadolol and then switched to propranolol. When I was, for both of them, I stayed off of meds for my first 2 trimesters. And then for the 3rd trimester, I was brought in on propranolol. And at that point, I had already been to Wisconsin. I knew that the babies had long QT. And so at that point, I was like, a huge advocate for, medicating myself and the babies through me. But it was the same with Suzy when I was nursing. I was on propranolol, so were they. So they were getting their dose. So if I remember asking though, is there a chance, could I potentially overdose them if they're getting their own dose and I'm getting mine? And then they nurse, and I was told absolutely not. That's not a concern. There was no need to change my dosage to try to sort of affect theirs. And I don't think I had any side effects from breastfeeding, like never while I was nursing, but there were definitely a couple times of those middle of the night feeds where with my oldest, she would cry. And from that sudden sleep to that sudden waking, I remember one time distinctly laying in bed and knowing, like just feeling my heart racing out of my chest and knowing I'm not going to, she's got to cry. I can't stand up right now. I can't, like, and because I was nursing and I wasn't pumping, she was, I was the only one that could stop her from crying. My husband couldn't do much, besides bounce her around. But I knew enough, like I could feel in my body, I knew that I was susceptible, in that postpartum period. And I remember just laying in my bed, and I was lucky, fortunate that it passed probably within, 30 seconds to a minute. But I remember feeling very uncomfortable, feeling definite, kind of something happening in my chest. And luckily it did pass. But again, I don't think that had anything it wasn't while I was nursing. It was just being woken up, which whether you're formula feeding, pumping, whatever you're doing, you're still being woken up. So I don't think it had to do with nursing. I think it just had to do with being a new mom who was long QT too, and might have been my postpartum jolt.
So yeah, one of the things that Ileana has asked is to all 3 of you is, how were your postpartum months and what were any precautions you took that you felt helped?
I don't know that I took any precautions really.
Yeah.
I mean, there was that where I was knowledgeable. I tried, I knew that was a period to be cautious. And so I did try to, try to pay attention, and sort of if I was in one of those like sudden waking things, I did try to sort of concentrate on my body first before, what my daughters needed, knowing that obviously they needed their mom more than they needed food at that moment. And so I was cognizant of it, but I don't know that I don't think I changed any of my behaviors really in terms of precautions.
We worked hard on making sure that I could get some sleep, some good nights of sleep. My husband did a lot to kind of protect some nights for me, so that he would take, like at the very beginning, when she was getting night feeds and stuff, he would take her to the basement and sleep with her down there in the little bassinet we had in the basement, so that I could get some peace for half the night. And then, when it was my turn. So we did a lot of kind of swapping like that. So that was really the biggest precaution I think that we took to make sure that we did a little extra safety.
And I think for me, actually knowing that the postpartum phase was risky that actually was a big factor in really helping cement I knew I wanted to be a stay-at-home mom, but there was sort of the pressure of like, oh, but like, should I keep working or I can do it all? And knowing about that being a high risk time, that really helped inform and cement my decision of like, I need to stay home. And I know that's not the choice that everyone makes, but I know myself and how I handle stress and how I do when I'm overwhelmed. And I knew that for me personally, it was just going to be way too much to be trying to care for a new baby and care for myself and also work. And so, yeah, with my daughter, I stopped working and became a stay-at-home mom. We also did make a big move when she was a month old, which in retrospect, I'm like, that was not very well timed, not good timing. But we did what we needed. Yeah, we did what we needed. Yeah, we did what we needed to do.
Bad idea.
No, do not recommend. But we did what we needed to do. And then by the time my son was born, I had picked up some freelancing jobs and a little bit of part-time work from home that was very flexible, very remote. But after he was born, I completely stepped away from that for, I think 2 or 3 months. I stepped back from everything just to give myself time to adjust and kind of eliminate any outside stress from my life.
Thank you all. Mm-hmm. So Ileana also asked Dr. Spears and Dr. Strasburger, is it correct that babies are smaller if the mother is on beta blockers during pregnancy?
So I think that these are incredible discussions, because these things come up so frequently. And just to address the breastfeeding issue, I think that early observation that the postpartum period was very high risk for women with long QT syndrome is part of where the breastfeeding mythology came from. Because I think at first it wasn't a clear understanding of what the triggers were and what was happening physiologically postpartum. And when they saw that women were dying in that first 9 months postpartum, I think the logical conclusion was that this may be related to breastfeeding, and now we know that that's not the case. And that, if you're well beta blocked and managed properly, that your risk is very, very low, and that breastfeeding is perfectly safe in long QT syndrome. And so, it saddens me that is still out there, and I know that it's out there, and I hear it a lot. But I'm glad that you guys are, you're a very well-informed group, and you're advocating for yourselves, and importantly, you're teaching your caregivers who are going to look after other women with this condition. And so that's one thing. And then to address the beta blocker issue, I think Dr. Strasburger may, she's more of on the fetal side of things, but from adult perspective, as you've pointed out, some of these babies have their own sets of issues with bradycardia or arrhythmia that sort of darken or sort of make the waters a bit more murky in terms of trying to tease out what is the cause of a low birth weight. So yes, they are being exposed to a beta blocker, and yes, we know statistically when we look at large cohorts of women taking beta blockers, they tend to have lower birth weight babies, but these women also have other cardiac disease, they have arrhythmia. In long QT syndrome, there's typically no structural heart disease, and you're not dealing with a high burden of arrhythmia. These arrhythmias tend to be quite sudden and catastrophic when they happen. And so, yes, I think statistically there is, as Dr. Cuneo mentioned, babies do tend to be lower birth weight, especially on higher doses of beta blockers, but these babies catch up and they grow and they become normal children. But I'm going to defer a little bit more of that to Dr. Strasburger's expertise in dealing with babies and the pediatric side of things. But yes, I always advocate that moms are breastfeeding, they're taking their beta blocker, and a little bit does get to the baby. So some of these beta blockers, propranolol and nadolol, are concentrated to a degree in the breast milk, a very tiny degree, and babies do get some of the beta blocker through the breast milk. But when you compare it to the doses that they're getting from their own medication dosing, it's a very small percentage of what their therapeutic dose would be. So it doesn't worry me at all when moms are breastfeeding on a beta blocker. So I'm not sure if Dr. Strasburger had anything to add to that, but that's my perspective.
I think you said it very well, Dana. The only thing I wanted to add was with regard to the infant. A lot of people don't know that if an infant gets a severe flu or is vomiting for 24 hours, can become dehydrated. We sometimes will see low blood sugar in that setting. So if the baby's lethargic, think low blood sugar, get the baby to the emergency room. If the baby's having persistent vomiting, check with your pediatrician. I've even sometimes seen kids have to be admitted to the hospital for IVs in order to, keep their blood sugar up during a bad bout of flu. Another thing, I don't know if any of the people who are here in the audience have Brugada syndrome, but with Brugada syndrome, with breastfeeding, it's important to watch out for mastitis because that can cause a fever, and of course, fever can trigger events with patients who have Brugada syndrome. So I think that's all I had to add. You really summarized things very well, Dana.
Okay, thank you both. We have a comment from Stace Pierce, who says her 27-year-old daughter's QT is always around 700. She has an ICD and has had appropriate shocks. She is on a beta blocker. Does her QT length put her in a higher risk than women who have borderline QT? So Dr. Spears or Dr. Strasburger, would you like to address that one? Dr. Spears?
So from an adult perspective, sorry, I'm just trying to see the chat. You said that she's had appropriate shocks. Okay.
Mm-hmm. Yes.
So the QT, the absolute or the corrected QT interval is something that we use to determine arrhythmia risk in long QT syndrome. So even though in women who have concealed long QT or they have had no history of syncope or events with long QT syndrome, we know that they're higher risk postpartum. But women who are at a baseline high risk, such as your daughter, so with a QT over 500 with a history of appropriate therapies from her device, yes, she is definitely a higher risk woman. However, being beta blocked typically drops that risk dramatically. Many cases of arrhythmia events in long QT syndrome in people on a beta blocker tend to be periods where there's non-compliance with beta blocker or poor absorption. So if there's a stomach flu and they're vomiting and not absorbing their beta blocker, that's when we tend to see breakthrough events. If we're seeing breakthrough events even on a beta blocker, then that's of course very concerning and requires appropriate titration of therapy or consideration of other interventions such as sympathetic denervation to control the arrhythmia risk. In that situation, then certainly pregnancy would need to be closely monitored in terms of arrhythmia and electrolytes. and whatnot. I wouldn't say that it would preclude pregnancy, but certainly it would require, you know, a bit more care and monitoring to make sure that we could, you know, get her safely through it.
Thank you.
I just had a comment about that, and that is that there have been patients who've had or non-pregnant patients that have had you know, arrhythmia storms with ICDs, and those can be treated with magnesium and isoprel. And there was a recent study looking at the effects of isoprel on uterine blood flow, and it actually increases uterine blood flow. So in a setting, a high-risk setting where there was, say, multiple shocks or something, that could still be used as an intervention that might, you know, be helpful in that setting. I think if she's a candidate for left stellate ganglionectomy, it probably should be done in a center where they do a lot of them, like Mayo Clinic or somewhere where a lot of them are done, because there is a you know, a skill set that goes along with that procedure. But, you know, like Danna, I wouldn't necessarily preclude the concept of a pregnancy with her. She just has to have, you know, really a good maternal fetal care team that involves an adult cardiologist like Danna, pediatric cardiologist like myself, and you know, a team that can respond in an emergency. I did want to just make a comment too, and it related to the idea that the cardiologist had told, I think it was Kellie, to stop her medication. And there is a difference between a regular cardiologist and an electrophysiologist. Most of us who are electrophysiologists have between 1 and 3 years of additional training geared specifically toward pacemaker, defibrillator, and arrhythmia management. And so I think that that you'll still find that, I think, and here's a plug for women, I think women electrophysiologists actually do a better job with pregnancy too. So if you have a chance to pick out somebody like Danna, you should, because I think there is a difference. And, you know, there was just a recent study published, I think in JAMA, showing that women doctors have a better all-around survival rate for their patients in general. And so I think, especially when it comes to pregnancy, I think sometimes women cardiologists and electrophysiologists do have a better knowledge of pregnancy than men. I'm sorry I hope I don't offend any of the men in the audience. I don't mean to, but you know, I think at this point, I guess I've gotten myself in enough hot water, so maybe I should stop talking.
Thank you, Janette. Okay, so back to our 3 moms. I have a question for you from our what we had discussed as far as what advice would you give to a new female with a SADS condition and a pregnancy? Any advice?
I think my biggest advice would be if something doesn't sound right, get a second opinion. I think that's kind of been a theme of our conversation all night, is get a second opinion. And also just really taking care of yourself during that postpartum phase. And remember, like, you know, yes, the baby needs care, but I think it's very easy to kind of get lost in that. And remember, you know, mommy needs care too. One thing I wish I'd done differently when my daughter was in the NICU, I had these visions of like, we're going to room in and I'll be with her all the time. And then when that didn't happen, I spent so much time pacing down to the NICU after my C-section. And I wish, like looking back, I wish that I would have used that time more to just rest more and trust like she is getting great care, and to rest and recover a little bit more. So just making sure that you're taking care of yourself, whatever that looks like for you, whether it's like Suzy said, you know, making sure that you're getting ample sleep, or, you know, whatever those needs you have are, just making sure that you're taking care of you.
Thank you, Kellie.
Yeah, I would echo what Kellie said. What other advice? I don't know what other advice I would have, except, you know, if you're someone who asks a lot of questions, then try and seek out those answers ahead of time, because it is a bit of a comfort to have that knowledge. And don't be afraid to seek out conversations with other people who aren't on your normal care team. So for me, I had spoken to Kellie and Melissa ahead of time, and they actually were really helpful in me, you know, kind of addressing those things that were a struggle for me emotionally about the idea of having a baby. And, you know, going to Wisconsin to talk to Dr. Strasburger, who provided advice I hadn't heard before. Like, you know, she just has so much knowledge to share. And so gleaning some of that was really, really helpful and advantageous. And just, you know, all of those things combined just kind of help you feel a little better and ultimately make you safer.
Thank you, Suzy.
Yeah.
Melissa?
And I 100% agree both with Suzy and with Kellie. And I would add on that, you know, I feel like it's almost inevitable that you're going to feel like, you know, no matter where you are, when you're in an MFM or an OBGYN office, you know, you're probably going to feel like a square peg in a round hole a bit, because you are, you know, we are anomalies in the general population of people who are having babies every day. But to me, what was super helpful was turning to SADS, having, you know, kind of, again, having that seed planted by Dr. Cuneo at a conference, where that was the first time I had heard about SADS and pregnancy. Then being able to reach out to her, like, you know, to me, the concept of being able to just email a doctor and them just email back when they're not on, you know, I'm not calling a receptionist and scheduling an appointment. Like, it was very, very, you know, familiar versus the clinical side of things. And so I feel like that's what led me to the study in Wisconsin, which led me to having those notes from Dr. Strasburger that were then referred to by my anesthesiologist, by the pediatrician in the hospital, by my MFM, by my whole care team. And so, Marcia, I don't know if you're up for this, but I would say, like, my advice is, like, email Marcia and get hooked into that network. You know, I mean, if that's, you know, that was just so helpful to me, because even though, I mean, I'm in Albany, New York. Yeah, it's not New York or Boston or Philly, but it's also not, you know, the middle of Montana, you know, in the middle of a lake where I'm 3,000 miles from, or 300 miles from a hospital. But there were a lot of gaps in knowledge in treating a woman with long QT and who had, you know, potentially children with long QT. So being that sort of square peg in a round hole of the general population felt really good to be able to come to people just like us, where we're all, you know, we're square pegs in a square board, you know. So it was really comforting, both mentally and also clinically. I feel like very much informative to the people who were actually my physical providers.
Any other ways that the SADS Foundation has helped you?
I think for me, part of it, just knowing, like, being able to help find good care, but also just knowing, for as long as I can remember, you know, from childhood, knowing, oh, the SADS Foundation is there. And I still remember, this isn't a pregnancy related thing, but I remember going to a couple conferences when I was a teenager. And actually, Eliana in our audience, I was like, oh, wait, we met at a conference a long time ago. So hi. But just knowing, I think, having that foundation of knowing, oh, there are other people out here with this. And so, like, I'm probably not gonna, you know, run into somebody with it on the street, but just knowing, like, oh, but there are other people out here living with this. So that's one thing I think probably the biggest benefit I've gotten from SADS is just knowing that there is there's that feeling of community and of not being alone.
And Eliana said hi. Go ahead.
Agree.
Yeah, okay. Go ahead.
Yeah, I completely agree with what Kellie and Melissa said. And it's, I don't think I had ever met anyone else with long QT until I was connected to the SADS Foundation, because it's not something that you really I never broadcast it when I was growing up, and I lived in a small community, and you know, no one asked. And so that was the first place I've met anyone my age who had another heart condition, and in particular long QT.
Yes, we met in Michigan at the 2018 conference. That's right.
Yes, yeah, we did, yeah.
Yes, and so any questions from any of our participants on the line? Comments, questions, put them in chat or just ask them verbally. I think we're kind of winding down on our time here.
I had a comment, and it had to do with Kellie. It reminded me of something that I think is really important to know, and that is the postpartum period is really a difficult period for all women, and especially with a beta blocker. The incidence of postpartum depression, not that Kellie had it, she sounds like she just had sort of the normal baby blues, but the postpartum depression is seen in 10% of all women, and it could be higher on a beta blocker. And so I think most people think of it as being tearful and but my experience with it is that one of the most common presentations of postpartum depression in women is forgetfulness. And that's important if you have a baby that's on a medication, and forgetting to give the medication to yourself or to your child can happen with postpartum depression. So it's sort of a warning sign. And I usually recommend keeping a calendar and having your somebody else besides yourself be responsible for seeing that the dosing is, at least the calendar is being kept up to date, because that can really be a clue to early postpartum depression.
Thank you, Dr. Strasburger. Any other comments or questions from anyone? Okay. Well, I want to thank our three presenters, Suzy, Kellie, and Melissa, as well as Dr. Strasburger and Dr. Spears. Appreciate your time today. Yes, thank you, thank you. I saw that. And so we appreciate you sharing your stories and addressing some questions. And if any, I put a email in our chat box, sads@sads.org, if you have any other further questions. So thank you very much for your time, and have a good evening.